Thank you very much for having me. I'm so excited to be for the first time at the All India Society meeting and among colleagues and so many friends. And thank you for the invitation from the organizers. Thank you very much. So does anyone recognize this person? This is a woman who presented many years ago, almost 100 years ago, to a physician in Germany. She presented with a bit of confusion, agitation, and this happens to be the woman who presented to Lois Alzheimer and first diagnosed with Alzheimer. And after she died, he looked at her brain under the microscope and was the one to first recognize this senile classic plaque, which to this day remains the corner hallmark of Alzheimer's disease. When we think about that particular disease, it's 27 million people, mainly 60 and older, progressive loss of memory neurons, and decline. Now look at glaucoma. We have 80 million people, mainly 60 and over, loss of vision neurons, and progressive vision loss. And we all recognize this as glaucoma. We have loss of the inferior rim, a disc hemorrhage. And I want to share with you a little bit of a journey that we had in undertaking our understanding of whether the changes that we see in the eye are actually evidence of a broader, bigger picture. This is a graph of where we had monkeys and we raised pressure in one eye. You can see the high pressure spike on one eye, and the other fellow eye was untreated. And after treatment, after lasering the meshwork to drive the pressure up, we looked at the optic nerves, and you can see the big fat black nerve that has about 1 million myelinated nerve fibers compared to, in the healthy control, compared to those that are affected by the high pressure. So you can see there's very little nerve fiber left there. But you know, when we look at this by electron microscopy at the optic nerve and we cut, they all look the same. You know, if you cut the optic nerve and you try to differentiate the neurons, we don't know what's what. Luckily, the eye is beautifully organized such that the cell bodies, the axons of the retinal ganglion cells actually terminate in the lateral geniculate nucleus. And there is an exquisite organization, both anatomically and functionally, that allow us to differentiate between magno in the first 2 layers, parvo in the dorsal four layers, and sandwiched in between we have our coniocellular neurons, which are responsible for blue-yellow signal. And what we found when we sacrificed these monkeys, when you raise the pressure in one eye and you look at the lateral geniculate nucleus, actually the lateral geniculate nucleus is affected, it's shrunken. And on high power under the microscope, if we label these neurons with calmodulin, what we see is compared to the normal plump, round, neurons on the left, you see that there are sparse, fewer, shrunken neurons. So we said, well, we need to measure it because in science we have to measure things. And so when we measured the number, we found that compared to the normal lateral geniculate nucleus in that brain center, 50% were gone. And so this was published as, evidence that in experimental monkey glaucoma, if you raise pressure in an eye and you look at the brain, the neurons die. So then we said, well, what about the cells that are left behind, the ones that didn't die? We found that they actually shrink. There's a shrinkage to the left. So you see the control is in red, and the green is the size measurements at all distributions, and there's a shift to the left. So we published this, and we said, for the ones that are left behind, there's shrinkage in glaucoma. But then we said, well, those studies were looking at specifically magno and parvocellular. What about the coniocellular? What about those, the yellow-blue pathway? These ones are sandwiched in between. You can see on your right, these neurons lighting up with CAMK2 alpha. When we look in glaucoma, again, they're significantly reduced. So we published this and we showed the three major vision pathways in glaucoma are affected when you raise pressure in an eye. And so it goes to show that if we have damage in the lateral geniculate nucleus, naturally one would expect that their projections to the visual cortex might also be affected. So we said, let's look at the visual cortex. And in the same monkeys, what we found is that in normal visual cortex, if you label it with cytochrome oxidase, which is a metabolic marker, you should see a homogeneous, even staining as you see on the top. But in glaucoma, you see alternating dark and light bands corresponding to the lower levels, which are driven by the glaucoma eye. So again, if you raise pressure in an eye, you see changes in the lateral geniculate nucleus, and they can be seen all the way to the visual cortex. So in primate glaucoma, we were fairly confident to say the neurons shrink, they die, all pathways are affected, and it goes to the visual cortex. So that's fine. These are animal models. What about people? So are they relevant? So let me share with you a case. This was a 79-year-old Caucasian gentleman who presented to me with open-angle glaucoma at an advanced stage. He died 18 months later. He had 0.9 cups, but he had previously consented for organ donation for research. And I'm going to show you what we found just before the chiasm at the level of the lateral geniculate nucleus and also in the visual cortex. So if we cut right before the chiasm, and this is our case compared to age-matched controls, we see that there's a significant shrinkage here. This is neurofilament stain. And if we look at the lateral geniculate nucleus, we see again the glaucoma through the biggest cross-sectional area. The lateral geniculate nucleus is smaller. And when we looked at his visual cortex, we found actually that he had a shrunken mantle. And so this was evidence that validated our findings in experimental glaucoma that said, you know, when you have human glaucoma, it's associated with degenerative changes in major vision changes centers of the brain. And this has really changed our understanding and even the way that we've defined glaucoma. And so this was published. But we said, well, what about patients who are in our clinics? Is there any way that we can look for this evidence? So we used 1.5 Tesla MRI available in any general hospital. We looked for the lateral geniculate nucleus. We blinded the three neuroradiologists to measure in our glaucoma patients compared to control population all of the heights of the lateral geniculate nucleus, which they often use in hippocampal studies to look for Alzheimer changes. And what we found was that there was atrophy of the lateral geniculate nucleus in the human glaucoma detected by MRI. This is 1.5, and since then there have been many other studies. So there has been an explosion of interest in seeing the brain, whether we're looking at microperfusion, structure, activity, or connectivity and metabolism. And here's an example of something that comes out of Japan. Here's another study that is looking at, you know, the visual pathway with DTI, diffusion tensor, different techniques to look behind the optic nerve, where here you can see 3T MRI Tesla, and it goes on. Here's something that identifies cortical changes, and if you do a literature search, you will see it's just the slope has really gone up in terms of the corroboration around the world using various approaches and techniques. So what we know is that in glaucoma, using structural MRI, things go wrong with the lateral geniculate nucleus. We know that even with the matter tract optic radiations in glaucoma, there are problems. And when you look at the visual cortex and beyond, there are significant changes there. So when we're trying to understand glaucoma, if you see all these changes, the contacts are destroyed, clearly this processing of the visual signal is disrupted, and it's understandable that we would have loss of vision. We've talked about the retino-geniculocortical pathway, but there are also retino-non-cortical corticogenic pathways involving the superior colliculus. Now, the superior colliculus is very good and important for eye movements. So we wanted to test out to see, is it something going wrong there? We used saccadic eye movements as a test. And we found that actually saccades, which we use for every day, looking quickly at our environment, scanning, going down the stairs, looking through the grocery store to see what items we want, they are delayed and affected. Could this explain the falls? Could this explain some of the driving accidents? So we see that if we look for it, we are seeing changes throughout the visual system in glaucoma, and there's a real opportunity to exploit these changes for repair, because right now all of our targets are on the eye. So the take-home message in closing is really that glaucoma is extensive disease involvement, and the visual brain is affected early, it's a biomarker, it's promising as a tool, and there's really some big opportunities to slow disease progression. So maybe we should target the entire pathway and the patient. And in closing, the next time that you look at an optic nerve, maybe we can consider in the clinic that this is just the tip of the iceberg. Thank you very much for your attention.